a little bit more vaccine stuff here. So the 23-valent pneumococcal vaccine, it's going to have capsular polysaccharides, and that will induce a T cell independent B cell response. You have to know that. So it's basically only a B cell response. Whereas the 13-valent pneumococcal vaccine contains capsular polysaccharides that are conjugated to a protein antigen. And so this will induce a robust T cell dependent B cell response. So this will be a B and T cell response with the 13-valent pneumococcal vaccine. So one way to remember this, it's kind of a little bit wonky, but 13 is a lower number, but it actually has a more robust B and T cell response. And so I know it's not a great mnemonic, but sometimes just hearing somebody reason it out loud will help that stick. And something I wanted to note here is the oral polio vaccine will increase predominantly the IgA mucosal response. So those are some high yield vaccine points. I'm going to kind of litter in our lecture here with some memorization heavy topics like vaccines, just to make sure that you guys can hear that a couple times as well to sink that into your memory bank. Next, we're going to talk about hyper IgM. So we're sticking with the immunology here. This is going to have recurrent sinopulmonary infections with encapsulated bacteria. There's going to be more heavily biased towards viral infections with hyper IgM. And these patients will also see opportunistic infections like PCP pneumonia, so Pneumocystis jirovecii or Pneumocystis caryani, depending on how recent the resource is that you're studying. And so hyper IgM, you want to give antibiotic prophylaxis as well as interval IVIGs, kind of similar to your Brutons as well as common variable immunodeficiencies, where you want to give that IVIG infusion. All right, next, let's talk about hereditary angioedema. So these patients will have high bradykinin levels. Their C4 and C1 inhibitor levels will be low. And this is because the C1 complex is going to cleave all of your C4. And the C1 inhibitor levels I've seen tested, and this is more of a step 3 level question, but I've seen the C1 inhibitor levels be normal, but they're just poorly functioning. But for step 2 and step 1, make sure you know that the C1 inhibitor levels are low with hereditary angioedema. And so you can get bowel wall edema that causes diarrhea and vomiting in these patients. And it's going to most commonly affect the face, limbs, genitals, and it will be even worse after stress, trauma, as well as dental procedures. And so the treatment is C1 inhibitor concentrate plus bradykinin antagonist, also known as icatibant, or kallikrein inhibitors such as ecallantide. And so really what they'll test you on most commonly is the C1 inhibitor, right? Because you want to replace what you're low in, as well as bradykinin antagonism, because there's super high bradykinin levels. And so if you know the mechanisms of action, then you're a little bit safe with this type of a question. I have not seen them actually ask for icatibant or ecallantide, but they are good to be familiar with. A little note here, serum sickness is a type 3 hypersensitivity reaction. It's an antibody complex that activates the complement cascade. You get joint swelling, fever, and rash. Serum sickness is pretty tough to diagnose. You have to have it really high on your differential usually to get those questions correct. All right, moving on to a little bit about the rotavirus vaccine. And so a contraindication to the rotavirus vaccine is a personal history of intussusception. And it's also contraindicated if there's a history of congenital malformations in the GI tract that is uncorrected, such as a Meckel's diverticulum that has not had surgery. So I don't know why, but whenever I got this question, I thought that a pregnant household member would be contraindicated, but live virus vaccines can be safely administered to household contacts of pregnant women. You have to know this. It shows up on step 2 and step 3. And so if you have a pregnant family member or pregnant sibling or pregnant wife, for example, in the house, you can still personally get a live vaccine. Make sure you remember that. And you want to give the rotavirus vaccine at age 2 to 6 months. Next, a little bit more on common variable immunodeficiency. So they'll have a normal B cell count, but all the immunoglobulins are low. So I remember it's the common factor is that they're low and common variable immunodeficiency. And so Brutons, I remember the B for Brutons, B for baby, and then B for a low B cell count. All their immunoglobulins will also be low too. So you really want to look at the B cell count to differentiate Brutons from common variable immunodeficiency. And so Basically, what you can do here is, number one, remember that Bruton's is also called X-linked agammaglobulinemia. That will also give it away, right? Agammaglobulinemia means you don't have gamma globulins. And so don't get confused by the transient hypogammaglobulinemia of infancy, where you have decreased IgG, variable IgM, normal IgA and B cells. That usually normalizes by the age of 9 to 15 months with only mild infections in the meantime. That's just something to have on your differential, but usually they'll make these Brutons or common variable immunodeficiency questions very clear that it's an actual immunodeficiency. All right, common question that students miss is, should I still give vaccines to premature infants? And the answer is yes, you do not delay vaccines for preemies. So your 2-month-old vaccines, you have to know these, is the hepatitis B second dose, rotavirus, tetanus, DTaP, Hib, pneumococcal, and inactivated polio. And so the first Hep B vaccine is administered as soon as the patient weighs over 2 kilograms, which is 4 pounds, 6 ounces. All other vaccines are dosed based upon chronological age. And so just as a reminder, the first dose of the MMR and VZV is going to be at 1-year-old. Next, a contraindication to the DTaP vaccine is encephalopathy after previous dose or anaphylaxis to a vaccine component. If the patient had seizures after a prior dose, you can still give it. And so this is something where you'll have to definitely educate the family, educate the patient that you can still have a benefit/risk ratio that's in the favor of receiving the vaccine if they had a seizure. But if they had encephalopathy, then it's contraindicated. So make sure you're very clear on the patient's history. Seizure, still give. Encephalopathy, don't give. And so the dosing for the DTaP is at 2, 4, and 6 months. Then again at 15 to 18 months. Then again at 4 to 6 years old. You have 5 doses in total. So 2, 4, 6, 15 to 18, and then 4 to 6 years old. If a patient has infantile spasms/uncontrolled epilepsy, coma, decreased consciousness, or prolonged seizures within a week of the DTaP, you can't get the combo vaccine, so you give the patient the diphtheria and tetanus toxoids, and you don't give the pertussis component. And so, really important to remember that you would not give them the combo vaccine. You give them the diphtheria and tetanus toxoids without the pertussis. And so the pertussis prophylaxis is required for context of pertussis within the last 3 weeks. So if you're rounding in the hospital, you see a patient that has pertussis, you need to make sure that you get prophylaxis if you had contact within the last 3 weeks. All right, that is everything that I wanted to cover for immuno. Hopefully that was helpful.